Okay,
I'll also put that on charger. So
yeah, that's fine. So
no something.
I've started recording. I hope that's okay with you.
Yeah,
Because
that's
lots of
fine.
people, yeah, because lots of people won't be able to attend live, and they will definitely want to watch this later. So
Yeah, sure.
thank you very much. The reason I sort of wanted to do this is because, I thought that, the college does this twice every year or so. So why not do it informally? So just I made a list of all the people who got their Caesar in the past couple of years, and yeah, I think it will be very useful for everyone to hear about others' experiences. So I've introduced you to the group before, but if you don't mind, can you just tell us where do you work now? When did you get your Caesar, and how did you start your journey? Just talk us through it.
No, that's a great initiative, Mustafa. I mean,
Very much.
when we were doing our Caesar, we didn't have this kind of uh, a driven environment. And I would personally owe all my guidance to individual people whom I reached out. And again, life is a circle. So extremely grateful that I'm giving back what I got from my seniors and my mentors. So it's a way to just give back to your juniors and your colleagues to help them. So um, yeah, I'm working as a cornea consultant, substantive post now, with University Hospitals Morecambe Bay, which is Lancaster and Kendall. Quite place in the Lake District. So precisely, it's basically a corneal job plan, and yeah, um, I did.
And
I
when did you get your Caesar?
I had my Caesar in 2023, June
So
June
last year.
23.
Oh, June 23. That's exactly like me. Oh, no. I got 2024 actually. I got in
Yeah.
24. Yeah, yeah. Congrats. Well done. And when did you start your
So I started with this Caesar in 2019, gathering what is required, uh, had my exams and the pathways. So it's quite an arduous journey. But what I tell people around that the basic question with Caesar is, should we do that? Is it really worth it? That's the first and foremost question. And the simple answer is you would know it. Don't do just for the heck of it because someone next in your department has done or your friend has done it. No, your circumstances can be different. So it's absolutely a personal choice. It's not hard and fast. It's not a must thing, but it has to come from within because it's a long journey. There would be some sacrifices with your family time, long hours of paperwork, sign offs. So it's a long winding road compared to CCT. CCT is like a train from London to Glasgow. It would
yeah,
reach. You
yeah.
don't have to worry. Once you get onto the train, you are there.
Yes, I agree. It's
So
more straightforward, definitely.
yeah,
And we have to spend I'd say like double the effort comparing
yeah,
to CCT.
exactly.
Um,
So
yeah.
with Caesar, it's not so precisely defined pathway. There are lot many opinions, and when you look at all the guidance, well, you feel it's quite overwhelming, and then that's most of the people just they stop. Uh, so um, I
And
think
when you started collecting your evidence, was it all from the UK?
yeah. So 90% of my evidence was from UK.
And the rest was from
Rest was
India?
from Cleveland Clinic where I've worked in UAE, did my cornea and refractive work. But I would say I intentionally put only 10% of my evidence from overseas because that is a questionable part when it comes to submitting your evidence from overseas. And
Yes.
even that 10% was very basic, like you have those CRS forms, slit lamp examination, um, measuring intraocular pressure, ocular motility, visual fields, so I took like so you need to submit two evidence for that, two OSATs, two DOPS, two CRS for each. So I had taken the basic ones from there while I was uh, working there when I started my Caesar journey. So I didn't submit most of the evidence from overseas because I wasn't even aware of the nooks and corners and nuances of Caesar. You only get to know once you are in the country. That was
Yes.
what is required.
Yeah.
So in a way, it's advisable to submit 90 to 95% of evidence from UK itself rather than overseas,
Yeah. I
even
mean,
though they say that
most,
it's
yeah,
equal.
most of the seniors I know that got their Caesar had to use some evidence from outside the UK. Okay, but you are allowed. I mean, I
You are
know,
allowed, yes.
yeah, definitely. I know people who actually got their Caesar without even coming to the UK. So it is an option. But as you say, obviously the UK evidence is much stronger. So I agree with you. Yeah, people would try and aim to get most of the evidence from the UK. I definitely agree.
And there are people who have got Caesar from overseas, but we are talking about those that happened in 2004, 2005,
Yeah, long
when
time.
it was just introduced and things were not that rigid.
Yeah,
Uh, or if you are in US, there was a guy who was working in US, had two fellowships, and he submitted from US. So that's a little bit different situation
yeah.
compared to any other overseas countries.
Yeah. How about the FRC off? The big question now these days is, do you necessarily have to have FRC off? Do you know anyone who got their Caesar without FRC off?
I know one person who got Caesar without FRC off. Again, he got in 2019, 2018. He was FRCS Glasgow, but now these days we are hearing that college is trying to compare the competencies, and they write that, well, they say it's not mandatory, but it's advisable, and then you need to show very strong evidence in all the domains if you don't have FRC off. So it just quite it could be a tricky situation because Caesar is FRC off is only one part, and the other part is a lot of paperwork. And you don't want to be into that situation where you have submitted everything only to receive a comment that you do not have FRC off. Then what do you do? All your hard work for a year or for 2 years, 3 years,
Yeah,
submitting the evidence, and then you have 1 year to submit that FRC off. How can you ensure that within that 1 year you're going to pass all the parts of FRC off and submit that?
it's impossible. Within a
So
year, definitely not.
so it's not worth taking that chance, I would say that.
Yeah, I agree. It's just that, again, I've been obviously in touch with lots of colleagues there. The issue is, I'm sure you've heard that things are changing now, and there's a deadline for the old Caesar route in June 26. So seniors are now struggling because and they're not sure what to do. Should I apply through the old one or should I apply through the new one? That's the struggle. And lots of them do not have FRC off. So that's the issue. Are they going to be able to pass the whole exam within the next year or 18 months? That's the difficult part. Um, I don't know about you, but I still strongly suggest people submitting through the old pathway because it's much more known. Lots of people have got experience. The college has got experience through it, and it's. I think it's still easier. That's my opinion. They're saying that the new one is less paperwork, but I don't know. I slightly disagree, to be honest. What do you think?
Um, so you could submit the through the old curriculum. I think it could be submitted till June 2026. Is that right?
Yes, yes,
The easiest way to answer this question is depends on how far you are onto that journey. If you
yeah,
feel you have traveled 20%, then perhaps it makes sense to go for a new pathway and if you do not have FRC off.
yeah. I agree. Yeah,
And usually most of us, what happens, we do FRC off first and then start the paperwork, collecting paperwork for Caesar. Most of my friends have done like that. So
yeah,
FRC off is like the first part, and then we go to the next stage, which is collecting evidence. So if you feel you have collected almost 70% of CESR evidence, gone for 2 parts of FRC off, just the last part is remaining, then it's right to first focus on FRC off and simultaneously work on the last. 2026 is still far off. We got 1.5 year.
Yeah.
It could be done through the old pathway. The old pathway is good. There's the new pathway. They say it's less paperwork. You don't need 20 subspecialty clinics. Is that right?
Yes, but even the old one as well. I mean, the old one. I mean, last year, before the new curriculum came up, they came up with a new guidance, and then the new guidance was talking about that. There is no specific number still. So even the old pathway, they're not that strict with numbers. They're more interested about quality, and that's why I always say it's not about writing down 20 stable cases of keratoconus. It's useless. However, it's much better to write down maybe, let's say, 5 cases, but each with a different scenario, different management, different involvement. It's much better. It's the quality rather than the quantity. Yeah. So, so yes, I mean, they do say it's less paperwork, but it's not known. That's the issue. And in the last training day in Manchester, they kept asking Rob lots of questions, and they're not sure. Okay, we don't know because no one has applied through it yet. Obviously, they're not expecting someone to apply through it until the next sort of couple of years. So,
what does the new SSG suggest, Mustafa?
I mean, number wise.
Yeah.
Yeah.
Because
So I mean,
SSG would say everything.
no. So it doesn't say specific numbers clinic wise or patient number wise. Yeah. However, obviously there's I'm sure you've heard about the very big question mark about the cataract numbers. Have you heard about the 800? Yeah. So that's what people are not, happy about. That in the CESR guidance, the portfolio pathway guidance, it says 800 cataracts to achieve level 4, but in the training curriculum it doesn't. So that's why people are not happy, and the college are well aware of that.
Right, because in the old SSG there are 2 documents. If we are looking to submit from old pathway, the key documents are SSG and FAQ, and there's a Word document for CESR. Have this hard copy bound, read it 2 times, 5 times, 6 times. Every time you read, you would find something new. And believe me, they look very precise. When I submitted, so for an example, I will give you we have in FAQ, it is divided into subspecialties: cornea, retina, uveitis, neuro-ophthalmology. In retina, there is retinal screening for DR, and you could do an ROP screen. So there's a competency known as screening, and you could do either retinal DR screening or an ROP screening.
Yeah.
Even an ROP screening fulfills that criteria.
Yes.
I submitted ROP screening with 10 patients logbook of ROP, and as well as a letter from the pediatric consultant. But still they came back to me that I have not submitted DR screening. Because DR screening was specifically written in that FAQ. Right. So they would look to your application. You may have missed anything, but the assessors do not miss anything at all. So they caught me on few things where I missed. So we need two WPBAs for each. So there was a drugs in pregnancy. I submitted one, and I missed uploading the second CBD. So it's a CBD, right? Yes. So they came back to me that you have submitted one, but we are missing one CBD.
Yeah, they count every single one.
They count everything. They would not miss a single thing. And the best way is read your FAQ. When you make your index, submit your index the way the FAQ is formulated. Because first of all, they will tick box what is according to FAQ document. And if you're missing anything on that, that would be highlighted. So from the so there are 2 things. There's a summary table, which is 180 learning outcomes. Yeah. And there is FAQ, right? So 180 learning outcomes So if we are looking at FAQ on cornea, it would give like 12 or 14 outcomes, but the summary table would have more in the cornea than that.
Yeah.
So what I have done, uh, what I did was I submitted my index in the form of FAQ, same format, but added the missing ones which are on the summary table.
Right.
Below
Summary
that,
table meaning the learning outcomes, you mean? All the learning outcomes. That's what you
yeah,
mean by summary
yeah,
table.
learning outcomes, yes.
Okay.
So then I added the learning outcome below that, which were not on the FAQs, but in the form of FAQ. So because I've heard that the assessors on the old curriculum, they follow the FAQ, and if anything is missing, that's highlighted. So if you go in that pattern and then also add up all the outcomes which is on the summary table, that would kind of tick box that particular subspecialty. But
Yeah.
they are very, very particular. If you miss anything, they would come back.
Yeah. Let me add my take on this. So basically, my rules are that again, the learning outcomes are around, let's say, 180, something like
Yeah.
that. So for anything practical, so let's say the vision, pressure, whatever clinical, so clinical rating skills, you need two forms of each. Yeah.
Yes. Yes.
Although thinking about it, the FRC off should tick one of those boxes, yeah, because you have been assessed doing this, and
Yeah. Yeah.
yeah, but
But
it's
still
risky.
you need
Yeah,
to submit two.
it's risky. So definitely suggestible just to submit two of each. Okay.
Yes.
The
Yes.
other more important stuff is obviously the DOPS and the
Yeah.
OSATs.
Yes.
These cannot be ticked off by different forms. So someone before has submitted, let's say, a DOPS about doing the ultrasound, and then another CBD. That will not be counted because that's not enough. It needs to be two DOPS of that. Anything
Exactly.
practical needs
Yeah.
to be
Yeah.
the correct form.
That goes unsaid.
Yeah.
Yes.
So
There's no doubt
because
about that.
although it doesn't make sense. Like if someone before told me, no, it doesn't make sense. I'm a VR surgeon. I do lots of ultrasounds. I'm very senior. Why do they need two DOPS of that? Yes,
No,
these are the rules.
Mustafa, I would simplify that. We are not here to question. We are here to abide.
Exactly.
If
Yeah.
you want to question, pursue the CCT pathway.
Yeah. Yeah. I agree with
Uh,
that. Yeah.
and there's no point in debating why we need to submit two. This is what it is in SSG. So SSG says two competencies, two
Yeah.
documents.
Yes.
So and there are few gray zones which are, again, they might come back to you, but at least we should, from our side, we should try not to create gray zones as much as possible. Keep
Yeah.
it easy.
Yes. Yes. So just be on the safer side, I think.
Yes.
I mean, the assessors won't be sort of trying to, point out the missing stuff. It's just that if you make it easy for them, then they will make it easy for you. So in the whole application, if some tiny one thing is missing, maybe they'll pass it by. But if they found a pattern that, lots of stuff is missing, then what's the point? And they'll come back with recommendations. How many recommendations did they come back to you then?
So they came back to me with 4 or 5 recommendations,
Okay.
and 2 or
What were
3
they
of
then,
them
if
were
you don't
missing.
mind me asking? Yeah, so what, yeah,
2 or
two were missing.
so
Okay.
drugs and pregnancy was missing. Screening, they knew I was a cornea guy, so most of my recommendations were around retina uveitis.
Right. You don't care about the retina, do you? You don't look at the retina, you don't.
So uh, and like there's HPDP 11 or HPDP 1, which is prophylaxis or a laser contact lenses, something like that, cleaning
Yes.
the contact lenses. So
Right.
I did a CBD. It was there, but they were not very happy with the quality of CBD.
Yeah.
Uh,
Did they
and
mention why? Did they mention specifically why they were not happy? Was
No,
it?
it wasn't clear.
Right.
So I asked my seniors, okay, how do I go about it? Because they haven't mentioned specifically what's missing in that.
Yeah.
They didn't mention.
Okay.
So what I did was I made it more elaborate, discussed with consultant, uh, discussed the techniques of how to clean the lens and in a more detailed way. So Its quality of CBD is important. If you feel you write just 2 or 3 lines, no, that's not enough.
Yeah.
An effort should be shown, and the best way is just spread it out. Don't do more than 2 or 3 WBPs a week, because then the quality would be compromised.
Yes.
Don't bunch them.
Yeah. Yeah. I
You
agree
you
with
would
that.
be able to maintain the quality even if you space them and do it in a proper way. So in that way, it would show itself. Well, this is the right way to do that. And but I wouldn't say it was reasonable. All the recommendations were reasonable. There was one recommendation about YAG laser training. Now, I did submit logbooks with YAG lasers,
Hmm.
YAG PI, YAG caps lot me, but
Yeah.
they wanted a laser safety training course.
Oh yes, I've done that one. I've done one. Yeah. Okay.
So, so,
Is it not mentioned? Because I think there's one outcome called laser safety. Is it? I think so. Can't remember,
so
to be honest.
that laser safety training course, you, if you uh, I did not do the laser safety training course when I submitted initially,
Yeah.
thinking that my laser logbook would speak up for itself, that
Yeah.
I'm already doing actively lasers, YAG laser I dot me is like 70 or 100 laser.
That's that's the issue. You always assume. I assume.
Yeah,
I'm doing lasers, then I must be safe. But that's not
yes,
enough for them.
that's
Yeah.
not enough. So they asked me the laser safety training course, which I did and I submitted. That was okay. Then I took signatures from there's a laser safety officer in your trust, one of the nurses or senior, one of the SCTs would be assigned for that. So you need to take a letter on that as well. So that was one of the recommendation. Um, DR screening was one of the recommendation.
Yeah. So
Um,
what did you do about that? So the diabetic screening, what did you do about that?
I did attend the diabetic screening with the DR consultant.
Okay.
DR clinics, 10 clinics, um,
Right.
did 2 CBDs, and then
Yeah.
submitted that letter
Yeah.
from the
So
consultant.
that's a very good example because I did not have to attend diabetic screening. Yeah, I just attended the ROP, and I think I've done one CBD about screening or something. Maybe it was a hydroxychloroquine or something like that. So it's a very good example of how different evidence can be,
Exactly. That's what
and
I
how
did.
different the assessors can be as well. So it's
Yes.
not,
Yes.
there's no right or
So
wrong.
it's quite subjective. Like you did not do a DR screening, you submitted HCQ screening, which I did in my first application, and
Yeah,
I did an ROP screening, and I thought that would suffice because screening is on if you go on FAQ, screening involves uh, ROP or HCQ, but that didn't help. They came back to me for DR screening. So
interesting.
it's quite subjective. They would always come back with something, but as long as you show your effort, they would give that on your first application. Mostly, um, you will have nice comments. I had a very promising comment from the assessors. Nice, comprehensive application, very well organized. Effort was shown, but these are the recommendations. So if from the very first application, try to keep it very tight, organized, because that's the first impression. Your first time assessors, your second time assessors would be different from the first time assessors.
Are you sure about that? I did not ask
Almost,
Rob about this. So are you sure? Okay,
almost.
interesting. Right,
They could be
different. Yeah?
different.
Why? Why is that then? I mean, it's a bit odd. You'd
I,
assume that it should be the same assessor.
I think the reason being because there could be gradations of assessors, the senior assessors and people who have just started the journey. And
Yeah.
it's easier for second applications, second assessors to take up those applications because it has already been assessed by the first assessors and they have given the recommendations.
Yeah.
So the massive job has been done
Right.
because it's a big
And
onus on assessors as well if they are
yeah, sure.
approving an application.
Yeah. And when they came back to you saying, how long did the process take? I mean, you submitted first, then how long did it stay with GMC? When did the college come back to you? And then the review when you submitted the recommendations, how long did that take?
So I think six months time between my first outcome and the second one.
Okay, 6 months. Okay. It's not too bad. I mean,
Yeah,
I've heard of someone outside of ophthalmology got their reply within 2 months. So I'm sure it depends on the availability of assessors, obviously, which will really
because once
struggle.
you submit your recommendation after your first outcome, then the GMC would take 2 to 3 months,
Yeah.
uh, making sure you have done all the recommendations. It goes to a pathway, so it stays with GMC for 3 months almost, and then it goes to
Yes.
the college.
So even with the after the recommendation, does it go to GMC first?
Yes, yes, it goes to
Oh, okay.
GMC.
So it's the same. So the same process. Yeah.
Yeah, same process. It goes to GMC. You pay them again for resubmission, and
Yeah.
uh, and well, GMC does a good job because they make sure that all the recommendations have been addressed. They will come back to you. Are you happy with this? They have asked two competencies. So what I did, for all my recommendation, I submitted like 3 WBPIs rather than 2, just to be
Right. Just
very
to be
sure.
safe.
And also that also shows your effort, your inclination. You're not taking the things for granted, and
Yes.
you are you're trying your best. So that's helpful, and that's fair as well. Because if I have missed something, then like DR screening, I missed it. So I submitted a letter from the DR lead, showed evidence of attending 10 clinics, did 2 CBDs. So like there are 4 things triangulating
Yeah. Yeah.
with each other.
Let's talk about courses. So what do you think are the mandatory courses that everyone needs to do?
Microsurgical course, that's important. That's
Right.
mandatory.
Yeah.
Um, leadership and training.
Do you recommend a specific one?
I did one on online. You could do the RC of one if you can get the dates. If not, and you're too close to the time of submission, you can do any of the online ones available.
Okay. Anything else?
Train the trainer.
Yeah, there's a few on the college, by the way. So
Yeah,
I think anyone would do. So like 2 or 3 versions of it. So I think anyone would do. There are other even local ones across the
yeah.
country. So I think anyone would do. Did you have to write a reflection about any of these courses, or not really?
No, you don't have to write the reflection, but you have to write a reflection on a complaint. So that's mandatory.
Okay.
So
Second thing, because I did not write a reflection on the comment. it was it was a reply. So there was a complaint that came to me, and then I had to reply. So that's the only thing I've submitted. So, but not a reflection on the complaint itself. So
sorry, you're right. Reply, not the reflection. Yes.
reply. Yeah, yeah, fine.
So if there is no complaint, then you have to hypothetically create one
Yes,
and then respond to it.
yes, yeah. I'm sure everyone has got complaints. I'm sure this. And okay, and how about your audits? So how many audits have you submitted, and what
Yeah,
sort of topics were they? Were there different specialties?
yeah. You need 5 audits, and they have to be different specialties.
Yeah,
I chose one on glaucoma, uh, one in cornea, one on cataract refractive, one on casualty clinic audit, the distribution of cases, so something like service delivery. And
yeah,
the fifth one was, I think, again, it was on glaucoma, something like that.
yeah. And was it spread out, or was it? Can you bunch them in 1 year or two, or what
Yeah,
was it?
yeah.
Was it
So I did 2 in a year.
right? That's not too
So
bad. Okay.
yeah, yeah, you could do 2 in a year, no problem. That should be okay.
Yeah. And how about your cataract audit? Did you stick to the 50 consecutive cases, all consecutive, or did you bring back the patients? How did you deal with that?
No, that's a problem because not every patient would come back to you, and you would not have data on that. Um, the best way is what I did was I took 50 consecutive, but if I did not have the data, then I put that in my audit. Okay, I could not retrieve the data on these 10 patients.
Yeah.
So refractive spherical equivalent was not obtained for these 10 patients. But
Right.
then
And you mentioned that. Okay. Yeah.
I mentioned that. Yes, you need to mention that.
Yeah. I did something similar. So I had to involve actually not 50 cases. I had to put like 100 cases, but then these are the past 100 cases I've done, and then I had to exclude around 50. because these again did not have the data. So I just used the 50 remaining ones, and these were not consecutive. And I again mentioned it in the methodology, or however you want to mention it. Why did you exclude these cases? Because of this and this and this. And I think that was okay. I think that was accepted. That's not a big deal.
Yeah, they would know that. So you said you made it non-consecutive, and I made it consecutive, and I mentioned, well, we missed these 10 patients because you did not get the refractive, post-op refractive on
Yeah,
those patients. So, but all the other parts, intraoperative complications, post-op complications, you would know for those patients.
yeah, good, fine. Um, and did you, when you started working in the UK, was it only in one hospital, or did you have to move between different hospitals?
It was only one hospital, so I submitted my CESR from one hospital.
That's good. That's the best. So again, and were you a specialty doctor, or what sort of job did you have?
No, I started as locum consultant.
Locum. Which I mean, do you think it's more challenging? I always find it more challenging as a consultant. You're very specialized. You're very stuck in one specialty. You're not flexible to rotate. From your side and from the management side as well. Do you agree with that, or is it doable?
No, I would agree with that. So I used all my annual leaves for rotation.
Right.
So
Oh, annual leave. Wow.
yeah,
That's true dedication.
to
Right.
rotate into oculoplasty clinics because you need 20 clinics with dates, and your consultant
Yeah.
need to sign that. So if you have not
Yeah.
done 20 clinics, you need to put those dates on that Word document mentioning what cases you have seen, and the consultant needs signature. So you would have to do 20 clinics, pediatric ophthal, oculoplastics, retina. And in those clinics, that's the best way because you will find all those WBPAs pertaining to that subspecialty in those clinics. So if you're doing an
Yeah.
oculoplastic clinic, I'm doing a clinic, then I'll make sure I have to hunt for a lid ectropion. I have to hunt for a lid carcinoma, depending on what is this, what does that oculoplasty specialty tells me,
Yeah.
right? Uh, so in that way, you could do two WPBAs on each clinic, one clinic a week, and that will sort you out
Yeah.
automatically.
Um, yeah. I mean, now things are slightly more flexible, so you don't necessarily have to do the 20. I certainly did not do 20 in some of the clinics, and it worked. Although, I got some cases from casualty, for example. So again, for those who they think they're stuck in casualty and they think it's a waste of time, actually, casualty is a very big source of
Yeah, it is
cases.
a big source. Yes.
Yeah, I'm sure you've used casualty a lot.
Yeah, yeah. For all your uh, acute flashes, floaters, laser, disc edema. So casualty is chemical burns, chemical injuries.
Yeah,
We have DOPS for chemical injuries, irrigation, then disc edemas. So casualty is a good source for all these cases. Corneal ulcers, scraping.
yeah. Um, And I mean, they know as well that not all units have got a neuro clinic, not all units have got a uveitis clinic, for example. So in some occasions, it might be accepted to just get the cases from casualty. So do not underestimate casualty. I think it's a very big source of cases. And
That's
did you
true.
use, yeah, did you use logbooks, case logbooks, or how did you submit your evidence?
So, uh, are you talking about the surgical cases or?
No, the clinical cases. So how did you submit evidence of that? So did you have a logbook of each specialty?
No, I didn't. Some of my colleagues have done like 120 case logbook for each subspecialty with
Right.
writing the patient diagnosis management. Are you talking of that?
Yes.
No, I did not submit that. Um, I did have a little bit of doubt whether if I'm not submitting that, how would that be taken? Would the assessors come back to me? But then SSG doesn't mention that you have to submit the case logs. It's the clinics, 20 clinics required. Now, when I took the letter of 20 clinics, what I did, I put the dates of 20 clinic dates and also a big two paragraph what I did in those clinics. So let's
Yeah.
say for the oculoplastics, if you read the FAQ, you it tells you what you need to cover in that subspecialty. So in that letter, I have mentioned that I have seen 5 thyroid cases. I have read the radiographs. I have discussed this, seen ectropion and tropion patients. So basically, the summary of your case logbook is kind of there in that letter.
Yeah, interesting, very interesting. That's good news actually, because the case
And
logbook is the thing that will take most of the time. Yeah,
yes, so it's not needed because that takes a lot of time and then the repetition of cases. So whatever is required from your FAQ, from your SSG in that subspecialty, you put that on the letter and do that
right.
as well,
Yeah,
because most of that would be your CBDs or DOPS or OSATs,
yeah,
right? And that, but you need to document that you have done that. So it would be a triangulation, because if you have submitted uh, suture removal, I think lid suture removal, skin suture removal is one of the OSAT, if I remember
yes.
that right.
I can't remember. All sorts of dops. I can't remember, to be honest. Yeah.
Something like
Okay.
that. So
Yeah.
if you put that on that letter with the 20 clinic date, so then that would be a good triangulation because your consultant has signed it. There's a WBPA, and then
Yeah.
you can put a corresponding letter.
Yes. Yeah.
So again, when coming to the patient letters, the best way what I did was whatever OSATs, whatever DOPS, the CBDs were done, I put the same letters, and then I put the codes on the letters. So let's say I have done a CBD on thyroid, that particular code, PM, whatever it is, that would be on the
Yeah.
letter. So
Yeah.
that's how the assessors would be able to triangulate your evidence. Okay, he has done a CBD. The CBD date he has put as 18th April. Okay, 18th April is also a date in his document where he has done his 20 clinics, right? And then we have a patient letter on 18th of April on thyroid. So that's a
Yeah.
triangulation.
Yeah. But you did submit a CBD, so CBDs are extremely important. That's actually the strongest piece of evidence, because these forms are the more or less the only documented evidence that someone has assessed you. That's primary
Yes.
evidence. That's
And I think
someone's
Rob,
comment on your performance. Yeah.
I think Rob has shared the CBD format with all of us at one point of time. What are the CBDs you should be submitting in the CESR course? Loss of vision. So they're like 20, 30 files with that, and you need to submit these 2 CBDs in each. So,
Yeah.
and most of those would tick box your 180 learning outcomes, what we have.
Yeah. Yeah. No, it's actually quite promising. I mean, someone asked me, is there any other way without logbooks? I told them that, definitely there's lots of people who submitted without logbooks. However, their CBDs and their other forms signed were very strong. So, as you said, it's not enough to say, this patient presented with this and this, and then what went well, he was good, or it needs to be better, see more patients. This is a very weak form. So, in that case, you need to show what you've actually done to the case, what you've been involved with, how did you actually manage the case as a senior person. So very important to write. It's for any form, if you remember, that the first box is description of the case, whether it's a DOPS or a CBD or whatever. And then in the last 2 boxes, it's what went well and what could be better.
Yep.
These are the main 2 boxes. They wouldn't care much if you're good or very good. Who cares? It's about what you've actually done well, because that's the only way you're going to associate learning outcomes to that for. Without that, then it's useless and you can throw it in the bin. So it's very important to write stuff properly. Um, the other question to you is, with the forms, I assume you used the e-portfolio back then,
Yeah, I use the
electronic.
portfolio. Yeah.
Yeah. And did you fill most of it out and then the consultant edited
Yeah.
it, or do you leave it empty, or what did you do?
I would always ask the consultants, how would you like to? You want me to fill all the form comments? It's very subjective. The best way is just reach out to them, ask them what they feel. Some of them, uh, one of my consultant, he said, no, I would like to fill him myself. So he would do it nicely, write elaborate comments, some of them would not write that, and you want some substantive comments on the last two boxes. So reach out
Yeah.
to them, ask them, but it should look nice at the end of the
Yeah.
day.
Yeah. Because again, I'm not sure if you've heard that they closed now the old e-portfolio, and now it's
Yes.
the new 14 fish thing. I'm sure
14
the
fish, yeah.
trainees, yeah, the trainees send you some forms now to sign it, and lots of people are struggling with it still. So it's still not, 100% functioning yet. It's got some glitches. So the advice was they can still use the forms downloaded, because you can definitely download them from the website. And you've got two options, either to fill it electronically with the consultant on their laptop or something, or maybe send it to their email, or even print it out. That's another option. Although the new forms are a bit tricky because there's lots of drop-down boxes and stuff like that, so it's a bit more challenging. However, the old CESR route, so for whoever wants to submit through the old one, because again the e-portfolio now has closed, now they've got again the two options whether to download it or send it electronically. So as Pratik was saying, that it depends on your supervisor. So you have to ask them, what would you prefer? Would you prefer me sitting down with you and then filling it all down on paper, or would you rather me sending out email? You can fill it on your own time. So it depends on the assessor or the supervisor.
Yeah, that's right. So in the new one, do they have access to 14 fish at the moment?
We do. So most of us do anyway. But lots of people have still issues and they cannot download forms, and lots of emails back and forth. And the reply was, okay, if you're struggling, then you might be okay using old forms even, or using the downloadable forms, not using it through 14 fish. So it's still doable, but it's just a bit more, there's a extra step they need to do.
Right. Yeah, I think the best way is to ask your consultant what they are happy with.
Yeah.
Yeah.
Yeah, and how about your maybe that would be the last question from me. Verifiers and references. So how many reference? Obviously, you've used only one verifier because you've got your evidence from one hospital. Yeah. How about your referees? So how many referees did you have, and what would be your advice on referees?
I had three referees. I think we need minimum three.
Yes, I think that's still the case. And the primary referee, was it your lead?
Yes, he was my clinical lead,
Okay.
primary referee, and I think all the three referees were consultants from different subspecialties. Um, it's important because the statements of referees have to be quite didactic, elaborate, to show you that you are competent and safe consultant.
Yes, it's a very long form, by the way. So I think it's like 20 pages or something. So choose your referees well. That's my advice. Someone I know, again, she got some recommendations. One of them that her lead um, gave the referee a form, the reference, but it was a useless reference because actually that lead did not work with her at all. So in most of the boxes, they said, I don't know, or I did not work with her. I cannot comment. There is no concerns. There's no issues. NA, those sort of things. So totally useless. So now there's a bit of flexibility as well. Um, you can put someone who's not the lead as your primary referee.
Yeah.
However, you need to mention why. That's one. You're doing that, and second of all, it needs to be a senior person, so like another supervisor or another lead, maybe I don't know,
Yeah.
college tutor or something, someone who's in a leadership position in the unit, and they need to have worked with you, because it's useless if it's someone that hasn't worked with you at all. Then how can they comment on your performance? So very, very important. That's a very, very essential thing. Um, Fine.
Is there a particular reference form for the referees?
Uh, no, so they send it. So the
It's an
college
open
sent
one,
it to
right?
them. Yeah, so it's split into domains. Again, they talk about skills,
Yeah.
leadership, whatever, probity, everything, and they need to write down some stuff. It's not
Yeah.
just he's good or he's okay. It's not enough. They need to write stuff. So and I think there is guidance for writing the reference form, I think somewhere, so they will guide the reference, the referee for that form. So they will tell them how can you fill it out. But it just needs some time. So you need to pick someone who's willing to help you out and willing to spend the time. Someone who likes you, basically.
Yeah, and again, the referees, it's desirable to have strong referees who are also known to the college. That makes a lot of difference.
All right, you
Someone
think so? Okay.
someone in prominent position supporting your application,
Yeah,
uh, that does make a difference as well.
yeah. Maybe like a Caesar lead or something in the region, maybe.
Hmm.
Okay, fine. I don't think I've got many more questions from my side. Let me read out a couple of questions and take a few hands. Let me take the hands first, and then we'll read the questions. Okay. So Aswini has got her hand up.
Hi, Mustafa. Thank you for arranging this. Hi, Prateek. I
Hi.
understand you've worked as a locum consultant. But my question, there are two questions. One is, you said you attended these clinics during your annual leaves, but you also have to submit your rota, which may show your annual leaves. Would that not be working against you, that you submitted these evidences on your annual leaves?
You you
B,
can you can work on your annual leaves. You are allowed
okay,
because
okay. Do you
uh,
have to declare it somewhere when you're showing evidences on those dates? Because I learned in the courses that when you show that you've done such and such surgeries while you were on annual leave,
hmm.
they may not consider it um, that she's faking evidence.
No, because if you take annual leave on Monday, Tuesday, to do your VR, like I took some annual leaves to do my 20 assisted VRs at
Mm-hmm.
Leeds.
Mm-hmm.
So that's absolutely fine. You don't
Okay.
I did not submit any specifically my annual leave rota for my whole year. I did not. I submitted my job plan,
Okay.
and my job plan was I was half day free on Tuesday PM. So what I
Okay.
used to do, I would do Tuesday PM half day um,
Mm-hmm.
oculoplastic clinics,
Okay.
and uh, if I used to take annual leave on Monday, 2 or 3 Mondays. Well, you
Mm-hmm.
are taking 4 or 5 Mondays in whole year to cover
Mm-hmm.
that, and it should be okay because
Okay.
um, it should not be a problem because even if you're working in your job plan, let's say you are on Monday AM PM, you're doing casualty clinic. Okay,
Mm-hmm.
you have submitted a VR competency on Monday. You took annual leave. That should be okay. I don't think there's anything wrong with
Agree.
that.
No, I don't think that'll be an issue at all.
No,
You
and
know,
you
lots
don't
of
need to
people.
declare your
Yeah.
attendance or annual leave that you have taken. They don't ask you that.
Right, thank you. And may I also ask, because you're a locum consultant, most of the times you may be working on your own without
Yes.
supervision from another consultant. So, how would you send these forms and to whom would you send, unless you've been working these extra clinics, going to someone else's clinic? When you're on your own and you've seen these cases, whom do you send these forms to?
No, I was with another consultant, always supervised in other specialties. So
Okay.
I was a cornea consultant. I was doing my independent cornea clinics theater. So my cornea consultant was happy to come over and supervise, just come over and see and sign me off for cornea scraping because independently I was doing that. So he didn't have any issues signing me off even without me doing a cornea scraping in his presence. Not
I see.
immediately, but after a few months when I was managing independently, then he was happy. But I always used to take two consultants for each learning outcome, not from the same person. So let's say there's a cornea scraping. I would not ask the same person to sign for both the cornea scraping form. I would take one from one consultant, one from the other consultant, just to avoid any bias.
That's ideal, obviously. That's the best scenario.
Right.
But
So
sometimes you don't
so
have two consultants. So
so in casualty clinics, I would call someone who is not a cornea consultant. I was one of my other substantive consultant, medical retina. I'll ask him, I'm doing a cornea scrape. Are you happy to sign me? He said, yeah, I'm more than happy to sign you off. So he would come in the room. I would do the scraping under his supervision. So it was all done under supervision.
I see. Thank you.
And same for the oculoplastic clinics. I would go into the clinics of oculoplastic consultant and take the cases in her clinic. And if I have to do a WBPA, I will tell her beforehand that I'm going to see this case, would like to do a case-based discussion with you. When was a good time? So she would see the case and she says, okay, then we can do the CBD next week. So attend her theaters, do the ectropion and tropion in her theater under her supervision when she's standing next to me.
Thank you.
Excellent. Ezra, you've got your hand up.
Yes, thank you. So I just realized today, I think we can sign for example, DOPS, OSATs, or other forms apart from CBD. They can be signed by the specialty doctors, even with the trainees. I'm not sure if it is just the way for the trainees or it works for us too. So today I just decided, for example, a slit lamp form to be signed by a specialty doctor or specialist doctor, because we only have 4 or 5 consultants always around which agree to sign the forms. So it's always takes time, 4 or 5 consultants. Now I'm collecting the forms. So will it give a disadvantage to me? For example, my forms are being signed by a specialty doctor or a specialist doctor instead of a consultant. Will it be a disadvantage?
Yeah, it definitely works. Yeah, so they say that the CBDs has to be a consultant. Do you agree, Prateek? Did you have all your CBDs signed by consultant, or did you have non-consultants signing off CBDs for you?
No, I had everything signed by consultant, even DOPS, OSATs. I did not take any chance.
Wow, you've got a very supporting consultant team. You definitely aren't allowed. So the easy stuff, so the sit lamp, vision, pressure, whatever, these can definitely be ST4 and above. Okay, but they say that CBDs need to be consultants. And again, the question is, Prateek, did you have locum consultants signing off stuff for you, or were they all permanent?
They were all permanent. Only one locum consultant was there who was in MedRet, and he signed, I think, again, 25% of the MedRet competencies. So I was, or maybe I preferred not to leave any stone unturned, no gray zones. So, yeah. I would be honest with you, if a consultant can do a CBD, they won't have any problem signing the slit lamp examination, IOP, tonometry, as long as it's electronic. You write them out you can ask them, would you like me to write it out on the comments? Because if you're working with them for 1 year, you're doing your cataract surgeries, casualty clinics, you are well versed. They know that you know how to do the slit lamp examination, measuring intraocular pressures, see the 90 diopter lens, disc examination. So it would not be an issue. Exactly. I don't think there would be an issue signing them off.
Sometimes they sign it off without actually seeing you in the clinic. Yeah, so most situations are okay with that. It's not that strict. But obviously the other more complex stuff, like doing a scrape or removing a suture or doing an ultrasound or whatever, these are more sort of they need supervision.
And the best way is you attend a consultant list. Like I attended my cornea consultant list when I joined as a locum consultant. I did few of cases under his supervision in his theater. So he was very confident, and then he signed me off for that case. So you need to build a rapport. They should see you as a person with confidence, and they would not hesitate. But if they see you as a person who is just trying to tick off the box just for the heck of paperwork, no, and that's also not right. And it comes if you show your dedication. And I mean, if you don't have to show your dedication, if you are dedicated, it would just happen. You will find everyone on your side, on your team.
Someone just asked me again about cataracts. He didn't fulfill the full number of cataracts, and some of his cases, or majority of his cases, was assisting in the cataract. And then the question is, would that be considered as part of the 350 or not? And then I just told him a very simple sort of reply: you have to ask yourself, are you ready to be a consultant or not? You know, because once you're done, now you're on your own. You know, maybe you don't even need a fellowship and then just, go ahead to be a consultant. So once you've got CESR, that means that you're an ST7 equivalent. So you should be ready to be a consultant actually. So it's not just about paperwork. Yes, CESR is majority paperwork, but it's just about you as well being ready. Yeah, it's not just about ticking the boxes. Just think about that.
Exactly. I would say the paperwork is there, but the WPPAs are not paperwork. There's a lot of learning, and it grooms you well. So
Yeah.
the paperwork is okay. Submitting your publications, writing a reply to the complaint, all leadership management courses, submitting and accumulating that. But WBPAs are your clinical. It goes a long way. So.
Yeah, I agree.
And then you're going to be in the same shoes when you have your trainees. So if you have done it the right way, then you would know what is the right way to sign them off.
Yeah, I agree. If there is no other hands raised, let me take a couple of questions in the chat quickly. Someone asked about the fellowship exam. On the scale of the CESR road, what is the percentage if I completed 2 exams of it? I mean, is it 30% of the route? I think the exam is a bit more than 30%. Do you agree, Prateek? How much percent do you think the exam is from the whole CESR route? Is it half of the way, or do you think it's less if they
Is
pass
it
that exam?
the weightage or it's the number of hours? Oh, I didn't get the question right.
Neither than me, but I think they mean that if they pass the exam, is that half of the way through the
Yes,
CESR route itself,
I would say
or
that.
yeah,
Yeah.
I agree. Because actually, if you look at the website, the college website, clicking on each learning outcome, if you open, it opens another window, and then it says that actually FRC off can be one of the evidence. Okay, so it does have lots of weight, and although in the guidance, either it's the old or the new, it says that it's not mandatory, but it's very essential and it's very clear. I definitely suggest doing the exam. That's out of the question, and quickly, yeah, because the longer you wait, the harder it gets. FAQ document. That's the. I mean, I've got. I can share it later. It's on the.
Yeah,
It's
it's
on
there
the.
online.
Yeah,
FAQ and the Word document. I could share that with you, Mustafa, and
yeah.
then you can
Yeah,
disseminate
I've
that.
got it. I've
Yeah.
got it. Yes, it's frequently asked questions. It's
Yeah.
if I remember, it's split according to the specialty. So each specialty, what learning outcomes is needed for each specialty, and the number of clinics and the number of surgeries, and
That's
so
the
on. So
Bible of Caesar. Read it as
yeah,
many times. And SSG. So just
yeah,
triangulate all three of them. You won't miss a thing.
yeah. You need to read. So people need to read lots of guys. It's all about the guidance. The UK is all about documents, so everything is there. And I'm sure now it's easier than before. You know, now there's lots of courses, there's lots of webinars, there's lots of documents everywhere, lots of WhatsApp groups. So the support is definitely there. There's no excuse, basically. Um, can I submit my diabetic eye screening clinic slip with letter? Um, I think that that's how you submitted your evidence, isn't it? So your diabetic eye screening was a letter from
Yes.
right
From my
from the
diabetic screening lead,
okay,
mentioning the number of clinic dates, what I have done, and then 2 CBDs along with that.
good. You mentioned 5 audits. Were they all just the first loop, or did you submit any completed audit loops?
So there was one completed one as well. You need to submit one re-audit as well.
Yes, so only one has to be the full cycle. Okay.
Yeah.
And I think now they're a bit more relaxed with audits. I think that now you're at least 3, not 5 even. So I think they're a bit easier on that now. But again, just to be on the safer side, maybe submit 4 or something. That's without the cataract audit. Okay, so cataract audit is out of
Yeah,
that
we're not
number.
counting the cataract one.
Yeah. In clinic letter, do we need to mention activities on each clinic day or in total rota? What do they mean by that? I'm not sure.
I think clinic letter means 20 clinic dates, what I have put, and then your FAQ will tell you what is needed in that subspecialty. Your Word document which is it an RC of, remind me, Mustafa, was it an RC of Microsoft Word document? Again, the CESR guideline, right? 2013.
You mean the
Word,
SSG?
no, SSG, FAQ, and the third document was a Word document, RC of CESR. It's there on net.
Yes, I've got it somewhere. There's lots
Yeah,
of documents
yeah.
actually. There's like
So
maybe
that
5,
that
6.
would tell you what is required in each subspecialty.
Yeah.
So in oculoplasty, for example, you need to study the neuroimaging, thyroid eye disease case, this. You put everything on that letter, and you do that before you put that on the letter. You make sure
Yeah.
that you have done that, and you do it, put it on the letter, so your consultant is happy to sign that. And 80% of the things what you have put on that letter, you would already do the WBPAs on that as a part of CBD or DOPS or OSATs.
Yeah.
So that obviates the need for that clinical logbook of 120 cases, which many people have done.
That's very reassuring, by the way, because lots of people have struggled. The other recommendation, other than case logbook, was case history. So case history is basically, rather than doing a CBD, it's writing the CBD basically. So, this case has presented with this. I've examined them
That's
this way. The
mostly
history.
of non-ophthalmology subspecialties with case histories. It's pertaining to other subspecialties rather than, specialties rather than ophthalmology.
I don't know someone personal who done case histories, but it's certainly written in the SSG. So, if you think of it, it might be a quicker way comparing to the case logbook is the worst. Case logbook is, it took most of my time. Just going to the notes and looking through the system, and it's just a heck of a time. So yeah.
Right. On that note, before I forget, I did the case logbook for neuro-ophthalmology because apparently from the old pathway, you uh, you are okay not doing the neuro-ophthalmology 20 clinics because neuro-ophthalmology is not there in every hospital. So
Yes.
they would accept the case log. I submitted 120 case logs for neuro-ophthalmology.
Okay. Very from casualty, I assume.
From casualty, yes, and general clinics as well. And got a letter from neuro-ophthalmology lead that he has seen a mix of cases. This well detailed in the case log of neuro-ophthalmology. He has been actively involved, done the CBDs pertaining to these cases. So again, you can format the letter from all the raw material you get on your FAQ, your Word document, and SSG.
Excellent. Okay.
That's the way to go about it. You'll get all the raw material, how to format that letter, but that letter should look nice and comprehensive.
Yeah. Regarding DOPS and OSATs for the new curriculum, do we have to submit 2 of each? Where can I find the forms for the assessment? This I can answer. So yes, you still need to submit 2, okay? But the forms, if you don't have access to 14 Fish, because lots of people don't, by the way, so lots of people actually are not having the affiliate memberships. They don't have access to the 14 Fish, the portfolio, or the iLook book. So that's not essential, by the way. You can use the forms outside of 14 Fish. You can use your own Excel logbook if you wish, the surgical logbook, that's fine. Although that's not advisable, but it's an option. These forms are available on the website. So if I've mentioned that in the last webinar I've done talking about the new curriculum. If you search, RCOF learning outcomes, you come up with a website, and then there's lots of buttons and lots of all the learning outcomes are there. If you click on each, it will open a new window with the link to the required form. So the EPA, the DOPS, the CBD, everything is there. Okay, so nothing is hidden. That's the take-home message. Can I use the old completed forms from the previous? Yes, so definitely you can. That's what the college has mentioned, because lots of people are aiming to submit through the old one, but then what if they run out of time before June 26 and they think, oh, I cannot submit now. Can I submit through the new curriculum now because I've run out of time? Yes, you can definitely. Do not throw it in the bin. Any evidence that you've got, you can definitely still use. Next question is, level 3 forms, can it be completed by an associate consultant who is not on the specialist register? So I think they mean a locum consultant. And I think that's a tough question. So I think level 3 is they talking about the new curriculum, which I cannot answer. Okay, so that would be better asked to Rob. Okay, so if someone can share Robert's email. Robert is a poor guy, you know, he's got millions of emails, so he's really struggling keeping up. But he will be the person to answer these questions because we don't know. Okay, so this has just come up, so we don't know. What's the best way to make sure we have covered all the learning outcomes? You suggest Excel sheets. Prateek, did you use an Excel sheet for your? You mentioned a summary table. Was that an Excel file?
The way I submitted was the Word document in the form of FAQ. And what I did, I kind of stratified my learning outcome based on subspecialty. And then there were a few of the learning outcomes like your ethics, attribute, AER, and all those things at the very end, research, that that I put as miscellaneous. This is the way I submitted my evidence rather than an Excel sheet.
Yeah, I definitely use the Excel sheet. I think I've shared it with someone before. I share it. I don't mind, but it doesn't matter. So whichever form you want to submit it, and but you need some sort of index file. Yeah, some sort of a summary sheet or whatever you want to call it, just to guide the assessor. Yeah, so you cannot just submit all your files and that's it. You have to have some sort of guidance. Can we get optoms to sign off for refraction? Definitely. Did you have an optom sign or was it still a consultant?
For refraction optom, yeah.
Yeah, okay. Optom definitely can, okay? And even orthoptists can as well, but they, you know, it has to be a senior orthoptist, can sign you off for extraocular muscles and confrontation field test. That is possible. Is what on 14 fish enough? Yes, because, you know, 14 fish is the portfolio, so you should find all the forms there electronically, but if you cannot use 14 fish, then you can use it electronically as well through the downloaded forms. We would be grateful if you can share the paperwork required with the group. Thanks. So paperwork required, that's like 1,000 pages worth. So that would be a bit tricky to share with everyone. But you know, the CESR groups on WhatsApp are very helpful. Okay, so and I think most of people who have got their CESR are still, you know, they're still on the group. So you can always ask, and documents are shared. You know that it's not hidden. Would it be okay to combine downloaded forms / paper forms with the e-portfolio forms and 45? Yes. So I think, Pratik, have you used any
Paper forms?
Handwritten, forms?
I used, I think, 2 paper forms or 3 paper forms for one of my locum consultant who was not on e-portfolio. And it's okay, you could use them because at the end of the day, when you are submitting your application, you're going to download an PDF form, right?
Yes, exactly. Just scan it.
And the paper forms, you can scan them. It makes your life very easy with e-portfolio or electronic. So I would still suggest going for e-portfolio or electronic or 14 fish now. Maybe wait some time. It's very tedious with paper forms. Yeah, it's not easier. And I remember scanning each and every letter and then redacting them, only to find that the redaction was still, they are very good. I thought I had redacted that nicely, and she said, no, we were still able to undo that. So you need to do it.
Okay, that's a very good question. That's a very good point. So how did you do it to start with?
So I had to purchase Adobe PDF redactor to do that properly.
Oh yes, but I mean to start with, how did you do it to start with, which didn't work?
Google. I just redacted with the Google Docs, with the Google PDF, and it does redact, and you would not know it. But then the GMC came back to me saying, no, it's not done properly. Right. Then I went again, all the letters and added work. And you would always miss some of the things. You have redacted the RTX, then you would miss the address. So there's so much on the letter. And if there are 100 letters, you will always miss. Please do not miss, because if you miss 2 or 3 times, they would ask you to do a course.
Yes.
And that goes into your application to the assessor. So please be very thorough. I was lucky. It didn't reach to that point where I was asked, be mindful of redacting every patient details.
Adobe is very good. I think that you have to subscribe. It's like £10 per month or something.
You can just put like a 2,000 budget for the CESR and put everything on that.
Yeah, just subscribe to it, maybe 1-2 months before you submit, and then you remove your subscription. That's not a big deal. But yeah, definitely, I've used the paper forms as well for the nurse Botox. She signed me off. I used it for evidence I got from Egypt. Again, that consultant was not on the register. And then a colleague, GP trainee, signed me off for IV cannulation.
Yeah,
works. Yeah, so it's flexible. I think lots of things are are not that strict. So
IV cannulation, I got signatures from my anesthetist who was on my cataract cases. So again, keep it diverse. Don't miss anything. Whatever is in summary table, just stick to it.
Yeah. Fine. And Islam is saying they state you should sign the evidence at least 3 months retrospectively on the new guidance, which is not very practical. How would they know? So let's talk about retrospective evidence. So, I mean, it's obviously a struggle with everyone, again, especially when you're senior and you're very senior. You go to the consultant and say, "Would you mind signing me off for a BCL that I've put in last year?" So, what would be your advice on that?
I won't ask that question at all. Ideally, what I used to do, I would ask them before they sign off. So I would go to them that I'm putting a BCL on this patient. Can you supervise me, and then I can send the form for you to sign off. So they are prepared. It doesn't demean you. It is not embarrassing for me to ask them, "Oh, I did something 4 months back. Can you sign me off?" Anyways, I do this every day. So what's the big deal? No, I won't do that. That's not right. That's not ethic. That's not professional. So ask them before, "Are you happy to sign me off for putting a bandage contact lens?" Now they could say, "Well, you are a cornea locum consultant. You do cross-linking. You put BCL. I'm happy, but give me a shout when you are putting in." So make it easy and make it comfortable for everyone, because that's not right. Asking retrospective signatures.
Yeah, I agree, because it doesn't make sense. I mean, in front of the college, it should be 2 weeks. That's the sort of number I've heard at different training days. So anything practical, so either a DOPS or SATS or CRS, maximum 2 weeks afterwards. Yeah.
And that also, I mean, it could happen you fail to send that form. So you've asked him, give him a shout for bandage contact lens. He has seen you. He's happy to sign. And you didn't send the form. You send the form 2 weeks after. That's okay. 3 weeks later, that's okay. That's not a problem. But asking something which you have done 4 weeks back and that is not being witnessed, that's not right.
Yeah, I totally agree. And by the way, I can see an assessor hidden in the audience today. So the assessors would know. Okay, so that's my advice. I wouldn't suggest at all writing anything retrospective, because these things are not tricky. If you've got someone supportive, they will be happy to sign you off prospectively. Okay, the only thing that can be retrospective is CBDs. Okay, a CBD, we can sign off a CBD now. We can discuss a CBD at any point of time, because you can sign off a CBD in teaching or in a conference or whatever. That's fine. But if it's something practical, how can I sign you off for something that I forgot about, and even you forgot about? So it's just waste of time, I think. So I agree. I mean, think of something recent, something that actually was witnessed. Okay, just do it properly. I think that's the way to go forward.
And I'll be honest with you, Mustafa, the CESR process is it transforms you. It makes you well-organized person. I'm so much organized now compared to what I was before when I started my CESR. And it's a learning. It's an improvement process, I would say. It's a long drawn journey, but it changes you to a more better organized.
That's the whole point. even if you're senior, you know, you might be very senior in your own specialty, but you know, ophthalmology is huge. You know, there's lots of stuff you need to learn well, especially in the UK, because remember, you're going to be on the on-call rota. You'll have to manage an optic neuritis. You'll have to manage retrobulbar hemorrhage or whatever. These things outside of the UK, we don't manage much, you know, because you're not on call, you're doing your private work, and it was years since you've last done a, you know, whatever skill you can remove a suture or something. So these things are very important if you are going to be a consultant. Just would look very weird if you're a consultant, you can't, you know, do a specific skill. Ezra, you've got your hand up.
Thank you. So I just wonder, for the forms, just one thing. Not all the forms are available in 14 fish. The 14 fish is now only, because I wrote back and forth to 14 fish. They said it is now just everything is just prepared for the ST6 and 7. And for example, the rest of the forms are not available. So you won't be able to find each and every form on 14 fish. But then you can download the forms, paper forms from either 2020 for curriculum or 2010 curriculum, and they are all accepted. But my question is, for example, on the outcome of any form like CBDs, OSAT stocks, we write, suggestions for improvement and development. There is always a suggestion, and then you need to back that up for the next form, isn't it? For example, using a slit lamp, you need to be more careful about the beam height, or you need to know more about the filters. You need to etc. So then you do another form, let's say in a month time, which is covering that part. Then you need to put another suggestion to improve more. So this is an endless loop. So I know that we are at least we need to submit 2 forms for each and every outcome. But then if we are going to put suggestions in each and every form, how we are going to end this? And is there an upper limit?
No. So even if they put a suggestion, you don't have to. You don't have to. Certainly do another suggestion in your next form. Okay, so you only 2 forms. If in the second form, if there's a few suggestions, you don't have to do a third one. Okay, so there's always a suggestion there, but only 2. 2 is enough. All right. Even so, for me, I do not focus much on the first one. What suggestion did it write down, and did I have to fulfill it in the next one? That was not that necessary. Okay, it's not that strict. I think we no it's I think that's out of our time now. So I'd like to really thank Prateek for his time. Thank you very much. That's been very useful, and I hope everyone has benefited from his experience. And I'll find out more about different applicants who got their CESR recently, and we'll repeat this hopefully. Prateek, obviously, you're more than welcome to join us later if you wish. But I'll and you wouldn't mind if I share this recording with everyone, yeah?
Sure, Mustafa. Please go ahead, and very happy to be contacted again if you need any further inputs. I know 1 hour is not enough. It's a long, many hours of questions, queries. So certainly, I'm happy to be involved more if you want to reschedule at one point of time. Yeah.
And can I take this chance to try and persuade you to be an assessor? You're not an assessor, are you?
No, I'm not an assessor at the moment.
You should be an assessor. People are really, that's the big struggle now. Yeah. So, and Rob is hunting for assessors. He really needs assessors because lots of people have complained about waiting times and stuff. So if you just think about it, maybe we can persuade you some way. Yeah.
Sure.
Thank you very much. Thank you very much, Prateek, and thank you to everyone. And I'll send the recording later, hopefully today or tomorrow. All right.
For sure.
Take care,
Thank
everyone.
you. Thank you.
See you. Bye now.